Endocrine disorders. The learning objectives for this presentation include the following. Identify disorders caused by variations in the hormones of the pituitary, thyroid, parathyroid, and adrenal glands. Explain the pathophysiology of each of the endocrine disorders presented. Describe the etiologies, signs, and symptoms of each of the endocrine disorders. Describe current therapeutic measures used for each of the selected endocrine disorders. List data to collect when caring for patients with each of the endocrine disorders discussed. Plan nursing care for patients with each of the disorders. Explain how you will know if nursing interventions have been effective. Let's start by reviewing what we mean by an endocrine disorder. The endocrine system regulates body functions through hormones, so when there's a disorder, it typically means there's too much or too little hormone activity. This imbalance can come from either overproduction or underproduction of a hormone, or from the body's tissues not responding correctly to it. For example, a gland might release too much thyroid hormone, causing hyperthyroidism, or not enough insulin, leading to diabetes mellitus. Sometimes, even when hormones are produced in normal amounts, the tissues don't respond as they should. This is called tissue insensitivity or decreased sensitivity. Now, when we categorize endocrine disorders, we use two main types, primary and secondary. A primary disorder happens within the gland itself. For example, in primary hypothyroidism, the thyroid gland is unable to produce enough thyroid hormone even though it's getting proper stimulation from the pituitary gland. A secondary disorder, however, is caused by something outside the gland, such as a problem in the pituitary gland, which normally controls many other glands, or due to factors like medications, trauma, or surgery. For example, removing the pituitary gland or damage from head trauma can disrupt hormonal signals to other glands. Another key concept is the feedback mechanism, which is how the body maintains hormonal balance. If there's too little hormone, the hypothalamus and pituitary usually increase stimulation. If there's too much, they decrease it. When this feedback loop is disrupted, such as when a tumor secretes hormones independently, it can lead to either hypo or hyperfunction. So what's the main takeaway? Endocrine disorders aren't always about one gland misbehaving. It could be the gland itself, primary, or the communication system controlling it, secondary. As nurses, understanding this distinction helps you anticipate what labs and treatments to expect, such as thyroid-stimulating hormone, TSH levels for thyroid issues, or adrenocorticotropic hormone, ACTH, for adrenal disorders. Reabsorption versus resorption. You've likely seen these terms in previous content, and they will appear again in multiple body systems, so it's important to clearly understand the difference. Reabsorption means absorbing something back into the bloodstream after it has already been filtered out. A good example is in the kidneys, where water, electrolytes, and nutrients are reabsorbed from the filtrate in the renal tubules back into the blood. This process helps maintain fluid and electrolyte balance and prevents the body from losing essential substances. Reabsorption is an active process, meaning it often requires energy in the form of ATP. The body uses energy to move substances against the concentration gradient. For example, sodium and glucose are reabsorbed actively in the nephron. Resorption, in contrast, refers to the breakdown and absorption of a tissue or structure itself. The best example is bone resorption, which occurs when osteoclasts, specialized bone cells, break down bone tissue, releasing calcium and phosphate into the blood. This process is important for bone remodeling, calcium regulation, and healing, but when excessive, it can lead to disorders such as osteoporosis. Unlike reabsorption, resorption is generally passive, meaning substances are broken down by cellular activity and absorbed without the need for active transport. In short, reabsorption happens when the body takes back something it still needs, like water or glucose, while resorption happens when the body breaks down tissue to release something, like calcium from bone. The terms are easy to confuse, but remembering the prefix re in reabsorption refers to again as in absorbing again can help you distinguish the two. Antidiuretic hormone, ADH, is also known as arginine vasopressin, AVP. This hormone plays a vital role in maintaining our body's fluid balance. It is made in the hypothalamus and stored in the posterior pituitary gland, which releases it when the body needs to conserve water. The main target organs for ADH are the kidneys, specifically the distal tubules and collecting ducts. Here's how it works. When the body senses that water levels are too low, ADH is released into the bloodstream. This causes the kidneys to reabsorb water, meaning water is taken back into the bloodstream instead of being lost in the urine. As a result, urine becomes more concentrated and the body maintains hydration. Now, when too little ADH is produced or secreted, the kidneys fail to reabsorb enough water, leading to increased urine output and excessive fluid loss. This condition is called diabetes insipidus, DI. Patients with DI may produce up to 10 to 20 liters of very dilute urine a day and often experience intense thirst, dehydration, and low urine-specific gravity. It's important to note that this is not related to blood sugar like diabetes mellitus. It's purely a water balance problem. On the opposite end, when too much ADH is secreted, the body holds on to excess water. This is called syndrome of inappropriate antidiuretic hormone, SIADH. In SIADH, urine output decreases because water is being retained, leading to dilutional hyponatremia. In other words, the sodium level in the blood drops due to water retention. Patients may have headache, confusion, muscle cramps, and even seizures if sodium levels get dangerously low. So the takeaway is this: too little ADH means too much urine and dehydration, DI, while too much ADH means too little urine and fluid overload, SIADH. I like to tell students to remember DI, dry inside, to help recall that diabetes insipidus causes dehydration, and SIADH, soaked inside, to remember that SIADH causes fluid retention. As you study endocrine disorders, notice that many of them come in these opposite pairs, too much or too little hormone activity, so focusing on one side can help you reason through the other. Let's look more closely at diabetes insipidus, or DI. This is not related to diabetes mellitus, which involves blood sugar. Instead, diabetes insipidus is all about water balance, specifically what happens when the body doesn't have enough antidiuretic hormone, or ADH, to retain water. In normal physiology, ADH tells the kidneys to reabsorb water from the filtrate in the distal tubules and collecting ducts so that it returns to the bloodstream. In DI, there's an insufficient amount of ADH, or the kidneys are unable to respond to it properly. This means water isn't reabsorbed and instead passes straight through the kidneys into the urine. As a result, the person diureses or urinates excessively, sometimes 3 to 15 liters of very dilute urine per day. This leads to dehydration and increased thirst as the body tries to compensate for the fluid loss. The main causes of DI include anything that affects the pituitary gland or hypothalamus, since that's where ADH is made and released. Common causes include pituitary tumors, head trauma, neurosurgery, or certain drugs such as lithium, which can interfere with ADH activity. It's important for nurses to monitor urine output closely, note changes in specific gravity, and assess for signs of dehydration such as dry mucous membranes, hypotension, and tachycardia. To remember this, think of DI dry inside, because patients lose so much water that they become dehydrated. If untreated, severe fluid loss can lead to electrolyte imbalances, especially hypernatremia. That's high sodium levels in the blood due to water depletion. Treatment depends on the type of DI. For central DI, where there's not enough ADH being produced, patients may receive desmopressin, DDAVP, a synthetic form of ADH. For nephrogenic DI, where the kidneys don't respond to ADH, treatment focuses on maintaining hydration and addressing the underlying cause. So, in summary, diabetes insipidus is all about too little ADH leading to too much urination and too little water in the body. As we continue through the presentation, we will compare disorders, one disorder that is associated with too much of a hormone versus the opposite disorder with too little of a hormone. Let's start with the hormone antidiuretic hormone, or ADH, and compare diabetes insipidus with the syndrome of inappropriate diuretic hormone. Diabetes insipidus. Remember, diabetes insipidus has nothing to do with blood sugar or diabetes mellitus. Diabetes mellitus involves insulin problems, while diabetes insipidus is caused by a deficiency of antidiuretic hormone, ADH. When there's not enough antidiuretic hormone, the kidneys fail to reabsorb water, leading to extreme urination or polyuria and excessive thirst, or polydipsia. The urine is very dilute, meaning it has a low specific gravity and low osmolarity, while the blood becomes concentrated with high serum osmolarity. Patients may crave ice water because they're so dehydrated. If this fluid loss isn't corrected, it can cause electrolyte imbalances, hypotension, weakness, decreased level of consciousness, and even hypovolemic shock or death. The most common causes of diabetic insipidus include pituitary tumors, head trauma, neurosurgery, or certain drugs like lithium. Diagnostic findings include low urine-specific gravity, less than 1, 0.5, and high plasma osmolality. A water deprivation test may be used to confirm the diagnosis. Treatment involves replacing fluids and using synthetic ADH, such as desmopressin, DDAVP. The nursing priority diagnosis here is deficient fluid volume, because the patient is losing more fluid than they're taking in. Now that we understand the pathophysiology of diabetes insipidus, let's talk about what we as nurses actually do for these patients. Because DI causes extreme water loss, our nursing care is primarily focused on maintaining fluid balance, monitoring for dehydration, and preventing complications. First, we must monitor daily weights, intake and output, and urine-specific gravity. Daily weights are one of the best indicators of fluid balance. Even small changes can reflect significant fluid loss or retention. Intake and output tracking helps identify whether the patient is replacing what they're losing. The urine-specific gravity is typically very low in DI, less than 1, 0.5, so monitoring trends helps us evaluate how well the condition is being managed. Next, we should monitor for restlessness or weakness, which are early signs of dehydration or electrolyte imbalance, particularly hypernatremia. Patients may become irritable, fatigued, or confused as sodium levels rise. Early detection prevents progression to more severe complications like decreased level of consciousness or hypovolemic shock. Providing fluids is essential. These patients lose large amounts of water through urination, and oral fluids should be encouraged if they can drink safely. If the patient cannot maintain hydration orally, IV fluids, often hypotonic solutions like 0.45% saline, are administered to replace water without worsening sodium imbalance. We also need to report decreased blood pressure and increased pulse, as these are clinical signs of hypovolemia, low circulating fluid volume. Tachycardia and hypotension indicate that the body is trying to compensate for fluid loss, and this requires prompt medical attention. Finally, it's important to encourage patient participation in their care. Teach them to track their fluid intake and output, recognize early symptoms of dehydration, and understand their treatment regimen. If they are prescribed desmopressin, DDAVP, or other ADH replacements, emphasize the importance of taking medications as ordered and monitoring for changes in urine output. Our nursing interventions are critical in preventing complications, promoting stability, and helping patients manage this chronic condition safely at home. Now let's look at the opposite problem, syndrome of inappropriate antidiuretic hormone, or SIADH. In this condition, there is too much antidiuretic hormone, meaning the body holds onto too much water. Instead of releasing excess water in the urine, the kidneys reabsorb it, causing fluid retention, concentrated urine, and dilutional hyponatremia, or low blood sodium levels due to excess water. The body becomes waterlogged. Symptoms include weight gain, confusion, headache, muscle cramps, and in severe cases, brain swelling, seizures, coma, or death due to hyponatremia. Causes of syndrome of inappropriate antidiuretic hormone can include central nervous system disorders, head injuries, lung diseases such as pneumonia or cancer, or certain medications including SSRIs, chemotherapy agents, or anesthetics. Diagnostic findings typically show low serum sodium, low plasma osmolality, and high urine sodium and osmolality because the kidneys are concentrating urine too much. Treatment focuses on treating the cause, restricting fluids, correcting sodium imbalances, and sometimes administering hypertonic saline carefully. The priority nursing diagnosis is excess fluid volume because water is being retained. An easy way to remember this comparison is diabetes insipidus, dry inside, like water loss and dehydration, where the D in diabetes stands for dry, syndrome of inappropriate antidiuretic hormone, soaked inside, water retention and swelling, where the S in syndrome of inappropriate antidiuretic hormone stands for soaked. Both conditions are opposites in almost every way: urine output, sodium levels, and fluid balance. Understanding these opposites is key to identifying and managing them properly in clinical settings. Nursing interventions for the syndrome of inappropriate antidiuretic hormone. What can we as nurses do to keep these patients safe and maintain fluid balance? Because SIADH causes water retention, the main goals of nursing care are to monitor fluid status closely, prevent complications of fluid overload, and maintain electrolyte balance, especially sodium levels. First, we need to monitor daily weights, intake and output, and urine-specific gravity. A sudden weight gain of more than 2 pounds per day may indicate fluid retention. It's also important to report any decrease in urine output, since this means the kidneys are continuing to hold onto water instead of excreting it. Daily weight is often the most reliable indicator of fluid status, better than intake and output alone, so weigh patients at the same time each day using the same scale. Next, fluid restriction is key. These patients are typically limited to 800 to 1,000 ml per day of total fluid intake. Every milliliter counts, so use calibrated cups to ensure accurate measurement. Remember, fluid restriction can be difficult for patients, especially those experiencing dry mouth or thirst. To help with comfort, offer hard candy, oral moisturizing gels or sprays, ice chips, or oral swabs to moisten the mouth. You can also recommend products like Biotin, which help relieve dryness. Encourage patients to avoid gulping large volumes of water, as this can worsen their condition. Changes in level of consciousness, LOC, are critical to report right away. A declining LOC may be the first sign of hyponatremia or cerebral edema. Along with that, nurses must monitor for seizures because low sodium levels can trigger them. Always have seizure precautions in place, such as padding bed rails and keeping suction equipment nearby. Encourage patient participation in their care by teaching them to monitor their own fluid intake. Recognize early symptoms of hyponatremia, like headache or confusion, and adhere to any prescribed medications such as loop diuretics, furosemide, or vasopressin receptor antagonists, conivaptan or tolvaptan. Finally, ensure the patient has a medical alert bracelet indicating SIADH or fluid restriction. This is particularly important if they're at risk for recurrence or if the condition is caused by chronic illness or medication use. In summary, your role as the nurse is to monitor, restrict, educate, and protect. The nursing priority diagnosis for these patients is excess fluid volume, and our interventions are aimed at preventing fluid overload, hyponatremia, and neurological complications. Growth hormone, GH, also known as somatotropin, is essential for the normal growth and development of bones, cartilage, and soft tissues. It's made and released by the anterior pituitary gland under the regulation of the hypothalamus. Growth hormone has many important functions. In children, it promotes linear bone growth, that means growth in height, by stimulating the growth plates or epiphyseal plates in long bones. It also supports protein synthesis and helps the body use fat for energy while conserving glucose, which is why growth hormone is sometimes called a building hormone. When the body produces too little growth hormone, children fail to reach their expected height. This condition is called dwarfism or growth hormone deficiency, and it results in short stature, slowed growth, and immature facial features. In adults, growth hormone deficiency can lead to fatigue, muscle weakness, decreased bone density, and poor quality of life because growth hormone plays a role in maintaining muscle mass and metabolism even after growth stops. On the other hand, when the body produces too much growth hormone, we see two distinct disorders depending on when it occurs. If the excess in growth hormone happens before the growth plates close, usually during childhood, the result is gigantism, where the child grows unusually tall but remains proportionate in body features. If the excess in growth hormone happens after the growth plates have closed, usually in adulthood, it causes acromegaly. In acromegaly, the bones can't grow longer, but they grow thicker, leading to enlarged hands, feet, jaw, and facial features. Other symptoms include joint pain, organ enlargement, especially the heart, and thickened skin. When you think of growth hormone disorders, remember this. Too little growth hormone results in short and small, dwarfism, while too much growth hormone results in large and long, gigantism or acromegaly. The photograph on the slide illustrates the dramatic difference in stature caused by these two opposite disorders. Now let's look at two opposite disorders involving growth hormone, GH deficiency and acromegaly. Both are related to abnormal secretion of growth hormone from the anterior pituitary gland, but they have very different effects on the body depending on whether there's too little or too much GH. Starting with growth hormone deficiency. When there isn't enough growth hormone during childhood, the result is growth failure or short stature, sometimes called pituitary dwarfism. These children often grow very slowly and may only reach a height of 3 to 4 feet as adults if untreated. They can also have delayed sexual maturation, a childlike facial appearance, and may seem younger than their age. In adults, growth hormone deficiency doesn't affect height, but it causes other significant problems. Adults may experience fatigue, reduced muscle and bone strength, weight gain, increased body fat, sexual dysfunction, and psychological disturbances such as depression or poor concentration. Because growth hormone also influences metabolism, deficiency can cause elevated cholesterol and blood sugar, which increases the risk for cardiac and cerebrovascular disease. Over time, these changes can reduce overall quality of life. The causes of growth hormone deficiency can include tumors, surgery, trauma, radiation, or genetic defects that damage the pituitary or hypothalamus. It can also result from severe emotional stress, malnutrition, or neglect. Malnutrition is the most common cause worldwide. Sometimes the cause can't be identified. To diagnose growth hormone deficiency, a serum growth hormone level can be drawn, but because growth hormone is secreted in bursts throughout the day, levels can fluctuate. A more reliable test is the growth hormone stimulation test, which measures growth hormone levels after the patient's blood sugar is temporarily lowered. Normally, GH should rise in response. MRI or CT scans can identify tumors, X-rays can evaluate bone age, and genetic testing may reveal inherited causes. When caring for a patient with growth hormone deficiency, your role as an LPN focuses on supportive care, education, and collaboration. Many of these patients have lived with short stature or growth hormone deficiency since childhood, so the most important thing is to approach them with respect, sensitivity, and professionalism. Always remember, short stature does not define the person. These patients may have faced social, emotional, or physical challenges throughout their lives. Approach every conversation with compassion and inclusivity. Avoid comments or behaviors that could be perceived as dismissive or patronizing. Your respectful attitude helps promote trust and dignity in your care. Next, ask about any current problems or challenges the patient is experiencing. Even though GH deficiency might have been a long-standing condition, adults can still experience new or worsening issues such as fatigue, depression, joint pain, or body image concerns. Listening to their concerns helps you identify changes that may need medical evaluation or adjustment in treatment. Many patients with growth hormone deficiency use somatropin, which is a synthetic form of growth hormone administered by subcutaneous injection. As an LPN, it's important to observe and support the patient's self-administration technique. Make sure they are storing the medication correctly, using proper aseptic technique, rotating injection sites, and safely disposing of needles. You can reinforce teaching, but should always collaborate with the registered nurse, RN, for detailed patient education, particularly regarding dosing, timing, and expected effects. Another key nursing role is collaboration, especially with the RN and other members of the healthcare team. This includes coordinating education, assessing treatment response, and reinforcing health teaching. Work together to ensure the patient understands how the medication works, potential side effects, such as joint pain, edema, or headaches, and when to report symptoms. Finally, connect patients with supportive resources. The Little People of America organization, WW, ELPA Online, Org is an excellent resource that provides education, advocacy, and community support for individuals with short stature and their families. By focusing on respect, patient-centered communication, and safe medication support, you play a vital role in promoting both the physical and emotional well-being of patients with GH deficiency. Now let's move to acromegaly, which is caused by excess growth hormone, usually from a pituitary adenoma or hyperplasia. In children, excess growth hormone causes gigantism, where long bones continue to grow excessively because the growth plates haven't closed. In adults, where the growth plates are already fused, excess growth hormone leads to acromegaly. Signs and symptoms of acromegaly include an enlarged jaw, brow, hands, and feet. Many patients notice that their shoe or ring size increases, or that their facial features become more prominent. They may have thickened skin, displaced teeth, tongue enlargement, macroglossia, sleep apnea, joint pain, and visual disturbances if the tumor presses on the optic nerve. Over time, the heart and other organs may enlarge, leading to cardiomyopathy, diabetes mellitus, and hypertension. These bone and tissue changes are permanent, even if growth hormone levels are later controlled. For diagnosis, growth hormone and insulin-like growth factor 1, IGF-1 levels are measured, along with CT or MRI scans to identify the tumor. As nurses, it's vital to remember that growth hormone disorders affect not only physical growth but also emotional well-being, body image, and metabolic health. Patients often need support adjusting to physical changes and adhering to long-term hormone therapy. In this slide, we are focusing on the primary nursing interventions for a patient with acromegaly, which, remember, is a condition caused by excess growth hormone, usually due to a pituitary tumor. As nurses, our goals are to help control the hormone levels, reduce symptoms, and prepare the patient for possible surgical or radiation treatment. One major intervention involves medications that block growth hormone. These include drugs like octreotide or lanreotide, which are somatostatin analogs, and they work by decreasing the release of growth hormone. Pegvisomant is another medication that blocks growth hormone receptors in the tissues, helping lower IGF-1 levels. As nurses, you may help in the administration of these medications and monitoring for effectiveness and adverse reactions. When reviewing these medications with patients, it is important to reinforce the need for ongoing monitoring of hormone levels and liver function because these medications require regular follow-up. Another intervention you see listed is hypophysectomy, which is the surgical removal of the pituitary gland or part of it. This is the most common treatment when the excess hormone is caused by a benign pituitary adenoma. As nurses, we prepare patients for surgery by teaching them what to expect and monitoring for complications afterward, such as cerebrospinal fluid leakage, changes in vision, or new-onset diabetes insipidus due to alterations in pituitary function. Radiation therapy may be used when medications or surgery cannot fully control the hormone levels or when the tumor is not fully resectable. Radiation works slowly, sometimes taking months to years, so it is important to teach patients that symptom relief may not be immediate. Nurses also monitor for long-term pituitary insufficiency because radiation often leads to decreased hormone production over time. When we care for a patient with acromegaly, our interventions focus on comfort, safety, emotional well-being, and long-term management. Many patients develop changes in the facial bones, especially the jaw, which can make chewing difficult. I want to emphasize the importance of offering soft, easy-to-chew foods so eating remains safe and comfortable. These patients often feel frustrated by jaw pain or difficulty chewing, so choosing foods that reduce strain can really improve their nutritional intake and overall quality of life. Education is another major responsibility. Acromegaly doesn't resolve immediately after treatment, and many patients require lifelong follow-up to monitor growth hormone levels and prevent complications like diabetes, hypertension, or heart enlargement. As nurses, we need to reinforce the importance of regular endocrinology appointments and routine lab work, helping the patient understand that successful management depends on ongoing monitoring. Body image concerns are very common because changes to facial features, hands, and feet can feel distressing or embarrassing. patients may struggle with lowered self-esteem or social withdrawal. It's important to create a supportive, non-judgmental environment, assess how these changes affect their feelings about themselves, and connect them with counseling or support groups if needed. Finally, we must monitor for complications that often accompany acromegaly. The enlarged tongue, soft tissues, and airway structures increase the risk for sleep apnea, which can cause fatigue and poor oxygenation. Joint pain is common due to overgrowth of bone and cartilage, and headaches may indicate tumor growth or pressure changes. Any new or worsening symptoms should be reported promptly because they may signal changes in pituitary function or treatment effectiveness. Here we can actually see the physical effects of acromegaly, which results from excess growth hormone, GH, secretion in adults. The images on this slide help us visualize how GH overproduction causes the bones and soft tissues to enlarge over time. In Figure A, we see a hand comparison between a person with acromegaly and someone with normal GH levels. Notice that the hand affected by acromegaly appears broader, thicker, and more square in shape. The fingers are widened and the tissues appear coarse and swollen. Patients often report that their rings no longer fit, or they may need to buy larger gloves or shoes. This is often one of the first signs that something is wrong. In Figure B, we see the facial and profile changes associated with acromegaly. These include an enlarged jaw, prognathism, a prominent brow ridge, and a broadened nose. The facial features become more coarse because of thickened skin and connective tissue. The tongue may also enlarge, macroglossia, which can cause speech changes, snoring, or sleep apnea. Over time, these structural changes are permanent because the bones themselves remodel and thicken, not just the soft tissue. Again, other symptoms not seen here but common in acromegaly include joint pain, spinal deformities, visual changes due to pituitary tumor compression, and organ enlargement, especially the heart. This increases the risk of hypertension, diabetes mellitus, and heart failure. As nurses, it's important to recognize these changes early. If a patient mentions that their shoe or hat size has increased or that their facial appearance has changed, these are key red flags. Early detection allows for treatment before irreversible bone and tissue growth occurs. When providing care for patients with acromegaly, remember that changes in appearance can be emotionally distressing. The nurse's role includes empathy, supportive communication, and referrals to counseling or support groups if needed. A hypophysectomy is the surgical removal of the pituitary gland, often performed to treat conditions such as pituitary tumors, Cushing's disease, or acromegaly caused by excess hormone production. This surgery is usually done endoscopically through the nose, a procedure called a transsphenoidal hypophysectomy, which minimizes external scarring but carries risks related to the proximity of the brain and sinuses. Preoperative teaching is essential. The nurse must first collect baseline neurological data. This gives us a reference point to compare with postoperative findings to detect any complications like bleeding, swelling, or brain injury. Next, patient education is key. It's very important that patients understand they must avoid any activity that increases intracranial pressure. This includes coughing, sneezing, blowing their nose, bending forward, or straining to have a bowel movement. All of these actions put pressure on the surgical site and can disrupt healing or cause cerebrospinal fluid, CSF leakage. To help them prevent this, teach them to perform deep breathing exercises or use an incentive spirometer instead of coughing to clear secretions. These exercises maintain lung expansion without increasing skull pressure. Patients are typically hospitalized for about 1 day if there are no complications. They should know that nasal packing and a small dressing under the nose, called a mustache dressing, will be in place after surgery to absorb drainage. Now let's move to postoperative care. The top nursing priority is neurological assessment. Monitor for changes in level of consciousness, pupil response, and limb movement. Any new confusion, weakness, or change in vision should be reported immediately because it may indicate swelling or bleeding near the brain. Next, monitor the urine-specific gravity. Remember that after pituitary surgery, there's a risk of developing diabetes insipidus, DI, because of disruption to the posterior pituitary. If the urine is very dilute, specific gravity less than 1, 005, and the patient is urinating large amounts, notify the provider. The nasal packing and mustache dressing should remain in place until removed by the surgeon. Observe the dressing for cerebrospinal fluid leakage, which appears as clear drainage that may test positive for glucose. You can use a bedside glucose test strip to determine if the drainage is CSF. If positive, report it immediately because it increases the risk of meningitis. Remind patients to avoid coughing, sneezing, straining, or bending to prevent pressure buildup and potential leakage. Finally, because the pituitary gland regulates other endocrine glands, patients will require lifelong hormone replacement therapy. This may include thyroid hormone, glucocorticoids, desmopressin for urine control, and sex hormones depending on which hormones are affected. Encourage patients to take these medications exactly as prescribed and never to skip doses. By providing clear pre- and post-operative education, monitoring for complications, and ensuring hormone replacement therapy is maintained, the LPN plays a vital role in helping these patients recover safely and maintain long-term stability. Patient education for patients who've undergone a hypophysectomy is a critical part of discharge teaching. Remember, the pituitary gland plays a central role in hormone regulation, so after its removal, patients need both physical care instructions and lifelong hormone management guidance. Before discharge, teach patients what to expect. It's normal to have a small amount of bloody or mucous nasal drainage immediately after surgery. However, any clear or watery drainage should be reported right away because that could indicate a cerebrospinal fluid, CSF, leak. Encourage patients to use a tissue gently, but not to blow their nose forcefully, as this can disrupt healing and increase intracranial pressure. To reduce straining and pressure, remind patients to take stool softeners as needed. Straining during bowel movements can put pressure on the surgical site and risk reopening the incision or causing bleeding. Similarly, coughing and sneezing should be minimized. If the patient develops a cough, they should take antitussive medication as prescribed to avoid putting stress on the healing area. If the surgical approach was transsphenoidal, through the nose and upper lip, oral care also needs to be modified. Instruct the patient not to use a toothbrush until the incision in the upper lip heals, as brushing could tear the sutures or introduce bacteria. Instead, they should use mouthwash and floss to maintain oral hygiene. Discuss hormone replacement therapy in detail. Since the pituitary gland controls other endocrine glands, patients will need lifelong hormone therapy to replace what their body can no longer produce. This may include thyroid hormone, glucocorticoids, desmopressin for fluid regulation, and sex hormones. Reinforce the importance of taking these medications exactly as prescribed and not missing doses, as skipping them could cause serious complications like adrenal crisis or dehydration. Finally, teach patients the warning signs that need immediate medical attention. They should call their doctor if they experience fever, clear or bloody nasal drainage, severe thirst, frequent urination, or any other concerning symptoms. These could indicate infection, CSF leakage, or diabetes insipidus, DI, which may occur if the posterior pituitary was affected during surgery. Your role as an LPN includes reinforcing these discharge instructions, ensuring the patient and family can demonstrate understanding, and helping them feel confident managing their recovery at home. This education not only promotes healing but can prevent life-threatening complications. This image shows the anatomy and surgical approach used in a hypophysectomy, which is the removal of the pituitary gland. The pituitary gland, sometimes called the master gland, sits at the base of the brain just behind the bridge of the nose and below the optic chiasm, where the optic nerves cross. You can see that it is located within a small cavity of the skull called the sella turcica, which is part of the sphenoid bone. The most common surgical approach shown here is the transsphenoidal route. In this method, the surgeon inserts an endoscope or special surgical instruments through the nasal cavity and sphenoid sinus to reach the pituitary gland. This technique avoids cutting through the skull and brain tissue, which makes recovery faster and reduces complications such as infection or brain injury. For the patient, it's important to understand that even though this approach is minimally invasive, it still carries significant risks because of how close the pituitary gland is to critical structures, such as the optic nerves, carotid arteries, and the hypothalamus. Damage to any of these can cause serious complications like vision changes, hormonal imbalance, or neurological symptoms. During surgery, the surgeon carefully removes the pituitary tumor or gland tissue while monitoring for bleeding or leaks of cerebrospinal fluid, CSF. After surgery, nasal packing is placed to control drainage, and the incision heals inside the nasal cavity. The patient may experience temporary nasal congestion or mild headache, but should not have forceful nose blowing or coughing, as this could increase pressure and cause a CSF leak. Understanding this anatomy helps you, as an LPN, visualize why postoperative instructions like avoiding nose blowing, sneezing, or bending forward are so important. It also helps you explain to patients that even though the surgery looks simple from the outside, it directly involves areas that control major body functions such as hormone regulation, fluid balance, and vision. Your nursing role includes reinforcing patient teaching, monitoring for complications like clear nasal drainage, headache, or visual changes, and ensuring the patient follows up for lifelong hormone replacement therapy. Now we're going to shift our focus to two opposite conditions involving thyroid hormones, hypothyroidism and hyperthyroidism. In hypothyroidism, the thyroid gland is not producing enough thyroid hormones, and when those hormone levels drop, the entire body begins to slow down. Metabolism becomes sluggish, and every system that depends on energy production is affected. There are 3 different categories of hypothyroidism, and understanding them helps us identify where the problem is occurring. In primary hypothyroidism, the thyroid gland itself is failing, even though the pituitary is sending plenty of thyroid-stimulating hormone. Because the gland isn't responding, the pituitary keeps releasing more thyroid-stimulating hormone, so those levels become elevated. In secondary hypothyroidism, the pituitary is the issue. It isn't sending enough thyroid-stimulating hormone to stimulate the thyroid. And in tertiary hypothyroidism, the hypothalamus isn't releasing enough thyrotropin-releasing hormone, so the pituitary and thyroid never get the signal to work properly. Most of the patients we see have primary hypothyroidism, and the most common cause is Hashimoto's thyroiditis, an autoimmune condition where the body slowly destroys its own thyroid tissue. As the metabolism slows down, patients typically begin to feel tired, sluggish, and unusually sensitive to cold. They may gain weight even if they are eating normally, and their heart rate and breathing slow down, which contributes to fatigue and shortness of breath. Many patients notice dry skin, brittle nails, and hair loss. The gastrointestinal system slows as well, leading to constipation. Because the nervous system is affected, patients may experience depression, mental fog, or memory problems. Cholesterol levels often rise, increasing cardiovascular risks. In more advanced or untreated cases, we may see myxedema, which is a buildup of a mucus-like fluid causing facial puffiness and swelling of the hands and feet. The most severe complication is myxedema coma, a life-threatening emergency typically triggered by infection, cold exposure, or abruptly stopping thyroid medication. These patients present with extreme drowsiness, very slow heart rate, low body temperature, and respiratory depression. When it comes to diagnosing hypothyroidism, blood work is essential. We typically see low levels of T3 or triiodothyronine and T4 or thyroxine. T3 is also known as the active thyroid hormone because it works more strongly in the body, whereas T4 is the prohormone because the body converts it into the active T3. In primary hypothyroidism, thyroid-stimulating hormone rises because the pituitary is trying to push the thyroid to work harder. But if the problem is in the pituitary or hypothalamus, thyroid-stimulating hormone will be low or inappropriately normal. Nursing interventions for hypothyroidism. Patients with hypothyroidism experience slowed metabolism, fatigue, and reduced energy levels, so nursing care should focus on promoting comfort, safety, and gradual recovery. First, it's important to assist the patient with self-care. Fatigue and muscle weakness can make even simple tasks, such as bathing or dressing, difficult. Provide help as needed, but also encourage independence to promote confidence and mobility. Next, ensure that the patient rests frequently and paces activities. Because their metabolism is slower, patients tire easily. Allowing rest between activities prevents exhaustion and supports energy conservation. As the patient's condition improves, gradually increase activity levels, but progress should be slow and closely monitored for signs of overexertion, such as shortness of breath, dizziness, or chest discomfort. Older adults with hypothyroidism are at increased risk for orthostatic hypotension, which means a drop in blood pressure when changing positions. This occurs because the slowed metabolism also affects cardiovascular reflexes. To prevent falls, instruct patients to change positions slowly, such as sitting at the edge of the bed before standing. Monitoring the patient's weight weekly is another important nursing action. Hypothyroidism can cause weight gain due to slowed metabolism and fluid retention. A sudden change in weight may indicate poor medication control or a complication such as myxedema. Collaborate with the dietitian to encourage healthy eating habits. This may include limiting calories if weight gain is significant, or increasing fiber and fluids to help relieve constipation. Encourage the patient to participate in setting realistic diet goals to increase adherence and promote autonomy. As an LPN, always collaborate with the RN for ongoing patient education. Reinforce teaching about thyroid hormone replacement therapy, such as levothyroxine. The medication must be taken consistently every day, ideally in the morning on an empty stomach, 30 to 60 minutes before food or other medications. Missing doses or taking the medication with food or supplements, such as calcium or iron, can reduce absorption and make the therapy less effective. When patients are treated for hypothyroidism, they are given synthetic thyroid hormone, such as levothyroxine, to replace the hormone their thyroid isn't producing. The goal is to restore the body to a normal balanced level called euthyroid. However, thyroid hormone dosing is delicate. If the patient receives too high of a dose, or if the dose is increased too quickly, the body may end up with more thyroid hormone than it needs. This pushes the patient from low and slow hypothyroid to high and fast hyperthyroid. For this reason, patients should also understand that too much thyroid hormone can cause symptoms of hyperthyroidism, such as palpitations, chest pain, or nervousness. These should be reported to the healthcare provider immediately. In addition, they should have regular blood tests to monitor thyroid-stimulating hormone, TSH, levels and ensure proper medication dosing. If the patient has mental status changes such as confusion, drowsiness, or slowed thinking, instruct them to avoid driving or operating machinery until symptoms resolve. Finally, assess for barriers to medication access, such as cost or transportation, to ensure adherence. Encourage the use of medication reminders or pill boxes, as hypothyroid patients may experience forgetfulness or mental fog that could interfere with taking their medication consistently. Hyperthyroidism is a condition where the thyroid gland produces too much thyroid hormone, causing an overall increase in metabolism. This condition is far more common in women, especially younger women with Graves' disease, while older women tend to develop it from multinodular goiter or toxic nodules. Hyperthyroidism occurs when there is an overproduction of thyroid hormones, T3 and T4. These hormones control the body's metabolism, so when levels are high, every system speeds up. The body's tissues also become more sensitive to stress hormones like epinephrine, creating that fight or flight effect. Patients feel jittery, restless, and anxious. Again, there are 3 different causes based on where the problem starts. Primary hyperthyroidism happens when the thyroid itself is overactive. Secondary hyperthyroidism occurs when the pituitary gland produces too much TSH, overstimulating the thyroid. Tertiary hypothyroidism occurs when the hypothalamus releases too much TRH, causing a chain reaction of overproduction. The term thyrotoxicosis refers to the effects of too much thyroid hormone in the bloodstream, regardless of the cause. The most common cause of hyperthyroidism is Graves' disease, an autoimmune disorder where the body makes antibodies that mimic TSH and overstimulate the thyroid. Other causes include toxic multinodular goiter, thyroiditis, and thyroid or pituitary tumors. Overuse of thyroid replacement medication can also lead to hyperthyroidism, so it's important to monitor patients on levothyroxine for signs of excessive dosing. Women who smoke have a higher risk of developing Graves' disease, and family history also plays a role in autoimmune forms. Because the metabolism is accelerated in hyperthyroidism, everything in the body works in overdrive. Patients often report the following signs and symptoms: heat intolerance, increased appetite with weight loss, frequent bowel movements, and tremors. They may appear nervous, anxious, or restless, and you'll often see a fast heart rate, tachycardia, or palpitations. If the heart can't keep up, it may lead to heart failure, especially in older adults. Another hallmark sign is exophthalmos, which means bulging eyes caused by inflammation and fat buildup behind the eyes. This is unique to Graves' disease. The skin can also thicken on the front of the lower legs, a finding called pretibial myxedema. Without treatment, complications may occur in which the body goes into a severe overdrive state called thyrotoxic crisis, also known as thyroid storm. This is a medical emergency. The patient develops a very high fever, severe tachycardia, hypertension, and mental confusion that can progress to coma or death. It's often triggered by infection, surgery, trauma, or sudden withdrawal from antithyroid medication. Immediate treatment includes cooling the body, IV fluids, and beta blockers to slow the heart rate, followed by therapy to correct the thyroid imbalance. In older adults, symptoms can be more subtle, sometimes showing as fatigue, depression, or apathy, so the condition can be easily missed. Diagnosis of hyperthyroidism begins with blood tests showing elevated T3 and T4 levels and a low TSH level in primary hyperthyroidism. In secondary cases caused by pituitary dysfunction, thyroid-stimulating hormone is high. Imaging such as a radioactive iodine uptake test or thyroid scan helps locate areas of overactivity or nodules. In Graves' disease, you'll see thyroid-stimulating antibodies in the blood. As we already touched on, exophthalmos is one of the hallmark physical findings in Graves' disease, the most common cause of hyperthyroidism. Exophthalmos refers to the abnormal protrusion of one or both eyeballs from the orbit. This occurs because of swelling and inflammation behind the eyes, caused by immune system activity. In Graves' disease, the same antibodies that stimulate the thyroid gland also cause inflammation and tissue expansion in the eye sockets. Fat and connective tissue build up behind the eyeball, pushing it forward. This protrusion is not just a cosmetic issue, it can cause significant discomfort and complications. Patients may have difficulty closing their eyes completely, which leads to dryness, irritation, and corneal injury. They may complain of eye pain, excessive tearing, a gritty sensation, or sensitivity to light, photophobia. Because the eyelids cannot close fully, exposure keratitis or inflammation of the cornea can develop. In more advanced cases, swelling of the eye muscles and tissues can put pressure on the optic nerve, leading to double vision or vision loss. The condition can worsen when patients smoke, as smoking exacerbates immune-related eye inflammation. Nursing care focuses on protecting the eyes and preserving vision. Patients should be encouraged to use artificial tears or lubricating ointment, especially at bedtime, to prevent dryness and corneal damage. They can also wear dark glasses to protect the eyes from light and wind. In severe cases, the healthcare provider may recommend taping the eyelids closed at night to prevent injury. When exophthalmos is pronounced, the patient's appearance can lead to emotional distress or altered body image, so therapeutic communication and emotional support are essential. Encourage the patient to express their feelings and connect them with support resources such as the Graves' Disease and Thyroid Foundation. Medical treatment includes corticosteroids to reduce inflammation and teprotumumab, Tepezza, a newer medication that targets the autoimmune reaction responsible for thyroid eye disease. In severe or vision-threatening cases, orbital decompression surgery may be performed to relieve pressure behind the eyes and allow the eyeball to move back into a more normal position. As an LPN, your role includes observing for worsening eye symptoms, teaching about eye protection measures, and reporting vision changes to the RN or healthcare provider promptly. Let's review the main therapeutic interventions for hyperthyroidism. The goal of treatment is to reduce thyroid hormone production and manage symptoms caused by an increased metabolic rate. One of the primary medications used is methimazole, Tapazole, which blocks the synthesis of thyroid hormones. It may take several weeks to months for hormone levels to normalize because it does not destroy existing thyroid hormone, only prevents new hormone production. Patients must take it consistently and have regular blood tests to monitor thyroid function and potential side effects like agranulocytosis or liver toxicity. Beta blockers, such as propranolol or atenolol, are prescribed to help manage symptoms like rapid heart rate, tremors, anxiety, and palpitations. These drugs don't lower thyroid hormone levels, but make patients feel more comfortable while other treatments take effect. Radioactive iodine therapy, I-31 or RAI, is another common treatment. It works by selectively destroying thyroid tissue, which reduces hormone production. This therapy is usually given orally and is effective for most adults. However, it's contraindicated in pregnancy and breastfeeding because it can damage the fetus or infant's thyroid gland. For patients who do not respond to medication or RAI, or when thyroid nodules or cancer are present, a thyroidectomy, partial or total removal of the thyroid, may be performed. After surgery, patients often develop hypothyroidism and will require lifelong thyroid hormone replacement. Now, in severe cases, we may see a thyrotoxic crisis, also known as thyroid storm. This is a medical emergency caused by an extreme increase in thyroid hormones. The nurse should recognize symptoms like very high fever, tachycardia, hypertension, agitation, and confusion. Treatment focuses on stabilizing the patient quickly, provide IV fluids for dehydration, use a cooling blanket to lower body temperature, and administer beta blockers to slow the heart rate. Acetaminophen should be used for fever, but avoid aspirin as it can increase free thyroid hormone levels. Oxygen therapy may be needed to improve tissue perfusion during this crisis. Nursing care for patients undergoing a thyroidectomy. A thyroidectomy may be performed for thyroid cancer, severe hyperthyroidism, or a large goiter that causes breathing or swallowing difficulties. This is a high-risk surgery because of the thyroid's rich blood supply and its close proximity to important structures like the laryngeal nerves and parathyroid glands. Before surgery, it's important for the patient to be in a euthyroid state. That means their thyroid hormone levels are stable and normal. If a patient goes into surgery hyperthyroid, they're at risk for a dangerous complication called thyrotoxic crisis or thyroid storm during or after surgery. To prevent this, providers will usually prescribe antithyroid drugs like methimazole, tapazole, and sometimes potassium iodide, which helps reduce the size and vascularity of the gland, decreasing the risk of bleeding during the procedure. As the nurse, you'll begin preoperative care by monitoring the patient's nutritional status because hyperthyroidism increases metabolism and may cause weight loss and nutrient depletion. Take baseline vital signs and check the patient's voice quality, as this provides a comparison after surgery to detect possible recurrent laryngeal nerve damage. During preoperative teaching, help the patient understand how to support their neck after surgery. Instruct them to place their hands behind the neck when sitting up or turning the head to prevent stress on the incision. Teach them how to use an incentive spirometer to prevent respiratory complications and reinforce the importance of deep breathing exercises. After surgery, postoperative care becomes critical. Monitor vital signs, oxygen saturation, drains, and the surgical dressing closely for signs of bleeding. A rapid pulse and drop in blood pressure could indicate hemorrhage or shock. Check carefully behind the neck. Blood can pool there unnoticed. Watch for respiratory distress or stridor, which signals airway obstruction from swelling, hematoma, or laryngeal nerve injury. Keep an emergency tracheostomy tray, oxygen, and suction available at the bedside. Observe the patient's voice. Ask them to speak occasionally to detect hoarseness or voice changes that may indicate nerve injury. Another key postoperative focus is calcium monitoring. The parathyroid glands, which regulate calcium levels, are very close to the thyroid and can be accidentally damaged or removed during surgery. When that happens, calcium levels drop and tetany can develop. Tetany presents with tingling in the fingers, toes, or around the mouth, muscle spasms, twitching, and even laryngeal spasms, which can compromise breathing. To confirm hypocalcemia, nurses may check for Kvostek's sign, facial twitching when the cheek is tapped, or Trousseau's sign, which is carpal spasm when a blood pressure cuff is inflated. IV calcium gluconate should be kept available for severe cases, and the nurse must report early symptoms immediately to prevent a failure to rescue situation. Another potential complication is thyrotoxic crisis, a sudden release of thyroid hormones triggered by surgical manipulation. The patient may develop fever, tachycardia, agitation, or confusion. This is rare but life-threatening, so vigilant observation is key. Remember, patients who have had a total thyroidectomy will require lifelong thyroid hormone replacement to maintain normal metabolism. Those who have had a subtotal thyroidectomy may still have partial thyroid function. Finally, emphasize patient safety and prevention of complications, particularly airway obstruction, bleeding, and tetany, as these are the top priorities in the first 24 hours post-operatively. Now let's take a few minutes to review the parathyroid glands and what happens when the body produces either too little or too much parathyroid hormone, also known as PTH. The parathyroid glands are 4 tiny glands located behind the thyroid, and even though they're small, they play a major role in keeping calcium and phosphorus levels in balance. When the blood calcium level drops, the parathyroid glands release parathyroid hormone, which signals the bones to release stored calcium, the intestines to absorb more calcium from the diet, and the kidneys to hold on to calcium rather than excreting it. Because calcium is so important for nerve conduction, muscle contraction, and heart function, any disruption in parathyroid hormone production has significant effects throughout the body. When the glands fail to make enough parathyroid hormone, calcium tends to stay locked inside the bones, and the blood calcium level becomes too low, a condition called hypoparathyroidism. This often occurs when the parathyroid glands are accidentally damaged during neck surgery, especially after a thyroidectomy, although it can also be inherited associated with autoimmune disorders or linked to low magnesium levels. Magnesium is needed to help regulate parathyroid hormone release, so chronic alcoholism or severe malnutrition can also trigger problems. Without adequate parathyroid hormone, calcium levels fall while phosphate levels rise. Remember, calcium and phosphate share an inverse relationship in the body. As calcium goes up, phosphate goes down, and vice versa. The calcium and phosphate imbalance affects both the nerves and the muscles. Low calcium makes the nerves overly excitable, so patients often develop numbness and tingling around the mouth or in the hands and feet, along with muscle spasms or painful, sustained contractions known as tetany. 2 classic clinical signs of hypocalcemia are Kvostek's sign, where tapping the facial nerve causes twitching, and Trousseau's sign, where inflating a blood pressure cuff on the arm causes the hand to spasm. If the calcium level continues to fall, patients can develop dangerous complications such as heart arrhythmias, seizures, or even laryngospasms that block the airway, making this a true emergency. Remember that a laryngospasm is a sudden involuntary tightening of the vocal cords that makes it hard to breathe or get air into the lungs. Diagnosis of hypoparathyroidism is based on laboratory findings showing low calcium, low parathyroid hormone, and high phosphate levels. An electrocardiogram, or ECG, may show changes related to calcium imbalance, and long-standing low calcium can affect bone density. Treatment depends on the severity of symptoms. Acute episodes require IV calcium gluconate to quickly restore calcium levels. Long-term therapy usually includes oral calcium and vitamin D supplements because vitamin D increases absorption of calcium from the digestive tract. If magnesium is low, magnesium replacement is also necessary to help stabilize parathyroid hormone function. As nurses, we closely monitor for early signs of tetany, report symptoms promptly, and ensure ordered calcium replacement is given. It is also important to teach patients to include calcium-rich foods in their diet, such as dairy products, leafy greens, and fortified grains to help maintain stable calcium levels. Kvostek's sign and Trousseau's sign. Both of these occur because low parathyroid hormone leads to low calcium levels, and low calcium increases neuromuscular excitability. As nurses, recognizing these signs quickly is critical because they can signal worsening hypocalcemia, which can lead to muscle spasms, seizures, laryngospasm, and even cardiac dysrhythmias. The first image shows a positive Kvostek sign, which is demonstrated by gently tapping the facial nerve just in front of the ear. If the patient has hypocalcemia, you'll see twitching of the facial muscles on that same side. This response happens because the nerves and muscles become overly sensitive when calcium levels drop. The second image demonstrates a positive Trousseau sign, which is actually a more sensitive indicator of hypocalcemia. To test this, you inflate a blood pressure cuff on the upper arm and maintain the pressure above the patient's systolic level for about 3 minutes. In a positive result, the hand and fingers spasm into what's called a carpopital spasm. This happens because ischemia and low calcium irritate the nerves, causing the muscles of the hand to contract involuntarily. As you teach or assess these signs, it's important to remember that both indicate neuromuscular irritability caused by low calcium. If positive, they require prompt reporting and intervention. This may include administering ordered calcium supplements, evaluating airway status, and monitoring cardiac rhythm because hypocalcemia can prolong the QT interval and put the patient at risk for dangerous arrhythmias. Nursing interventions for hypoparathyroidism. When a patient has hypoparathyroidism, their calcium levels are low because the parathyroid glands aren't producing enough PTH. As we've discussed before, low calcium, called hypocalcemia, can cause muscle spasms, tingling, and even life-threatening tetany. Tetany is the hallmark emergency complication we want to prevent. As LPNs, you must monitor closely for any signs of tetany, such as numbness and tingling around the mouth or in the fingertips, muscle twitching, or a positive Chvostek's or Trousseau's sign. If you observe any of these, it is critical to report immediately to the RN or healthcare provider, HCP, so treatment can begin without delay. Quick intervention with IV calcium can prevent airway closure or cardiac problems. A major risk in acute hypocalcemia is laryngospasm, which can obstruct the airway. That's why it's essential to make sure an emergency tracheostomy set, endotracheal tube, and IV calcium are available at the bedside. If a laryngospasm occurs, the airway can be quickly opened and IV calcium administered to relax the muscles. Because calcium balance is so tied to diet, nurses should also consult a dietitian to help the patient plan meals high in calcium and low in phosphorus. Encourage foods such as dairy products, dark green leafy vegetables like kale and broccoli, fortified cereals, and calcium-fortified juices. Patients should also be advised to avoid foods high in phosphorus, such as soft drinks and processed meats, because high phosphorus further lowers calcium. Patient education is a long-term priority. These patients will likely need lifelong calcium and vitamin D therapy, along with regular blood work to monitor calcium and parathyroid hormone levels. Explain that this condition requires consistent medication use, even if the patient feels well, because calcium levels can drop quickly if supplements are missed. It's also important to stress follow-up care. The patient needs to understand how to recognize early signs of low calcium at home, such as tingling, cramping, or mood changes, and when to seek immediate care. As nurses, we play a vital role in reinforcing this self-awareness and encouraging adherence to follow-up appointments and lab testing. This patient teaching helps prevent complications, maintains stable calcium levels, and supports quality of life after diagnosis. Hyperparathyroidism, again, is a disorder caused by overactivity of one or more parathyroid glands. When these glands produce too much parathyroid hormone, or PTH, the body develops an imbalance in calcium and phosphorus regulation. Under normal circumstances, parathyroid hormone helps keep these minerals stable by raising calcium levels when they drop. With excess parathyroid hormone, however, too much calcium is pulled from the bones into the bloodstream, the intestines absorb more calcium, and the kidneys hold on to additional calcium while excreting more phosphorus. Because of this, hyperparathyroidism leads to high calcium levels and low phosphorus levels. The most common reason this disorder develops is a benign tumor called an adenoma on a single parathyroid gland. Other causes include hyperplasia, where all 4 glands become enlarged, or in rare cases, cancer of the parathyroid gland. Some forms are inherited. There is also secondary hyperparathyroidism, which happens when another condition chronically lowers calcium levels, such as chronic kidney disease or vitamin D deficiency. In chronic kidney disease, the kidneys cannot activate vitamin D, so the intestines cannot absorb calcium well. As a result, the parathyroid glands are constantly stimulated to release more parathyroid hormone in an attempt to correct the low calcium level. Many patients do not show symptoms early on, but as calcium levels rise, the classic symptoms of hypercalcemia appear. Patients may experience fatigue, depression, confusion, loss of appetite, nausea, and vomiting. Because high calcium acts like a natural diuretic, they may also complain of excessive thirst and increased urination. Over time, calcium can accumulate in the kidneys, leading to kidney stones. Bones weaken as calcium is pulled out, and this may result in bone pain, joint pain, back pain, or pathologic fractures. When calcium levels become dangerously high, the heart and nervous system are at risk, and patients can develop arrhythmias, cardiac arrest, or even coma. A helpful memory device for these symptoms is the phrase stones, bones, groans, and moans, which captures kidney stones, bone pain, abdominal discomfort, and mental status changes. Diagnosis involves lab findings that show elevated parathyroid hormone, elevated calcium, and low phosphate levels. A 24-hour urine test may be used to determine how much calcium is being excreted. X-rays or bone density scans help identify bone thinning or fractures. If surgery is being considered, imaging such as ultrasound or specialized nuclear scans may be performed to locate the overactive gland. Nursing interventions for hyperparathyroidism focus on how LPNs can safely monitor and support these patients. The key problem in hyperparathyroidism is too much calcium in the blood, hypercalcemia. Remember, the parathyroid glands are overproducing parathyroid hormone, which causes calcium to leave the bones and move into the bloodstream. Because of this, our main goals as nurses are to lower serum calcium levels, prevent injury, and teach patients how to maintain safety and health at home. Start by monitoring for signs and symptoms of calcium imbalance. Hypercalcemia can cause symptoms like muscle weakness, fatigue, confusion, decreased reflexes, abdominal pain, and nausea. If calcium levels become too high, the patient can develop arrhythmias, kidney stones, or even cardiac arrest. Always report any new or worsening symptoms immediately to the RN or healthcare provider, HCP. Early detection is key to preventing complications. Encourage the patient to drink plenty of fluids, usually around 2 to 3 liters per day, unless contraindicated by a cardiac or renal condition. Hydration helps the kidneys flush out excess calcium and reduces the risk of kidney stones, which are common in these patients. Encourage water intake specifically. Avoid caffeinated or carbonated beverages, as they can increase calcium loss from bones or affect hydration status. Next, emphasize strengthening and weight-bearing exercises. These activities like walking, light resistance training, or using resistance bands help the body deposit calcium back into the bones and slow down bone loss. Bed rest should be avoided because inactivity can worsen bone demineralization and increase serum calcium levels. Because the bones are often weak, provide a safe environment for ambulation. Falls could easily cause fractures. Make sure pathways are clear, provide assistance when walking if needed, and encourage patients to use supportive footwear or mobility aids. Preventing falls is a critical safety intervention for these patients. Also encourage smoking cessation. Smoking contributes to bone loss and decreases the absorption of calcium in bone tissue, which can worsen osteoporosis and hypercalcemia-related bone weakness. Offer resources such as nicotine replacement or referral to a smoking cessation program. Patient education is another key role for the LPN. Teach the patient how to recognize and report symptoms of both hypercalcemia, like weakness, fatigue, confusion, or polyuria, and potential hypocalcemia after treatment, such as tingling around the mouth or muscle cramps. Explain the importance of long-term medication use, for example, calcium-lowering medications like cinacalcet, Sensipar, diuretics, or bisphosphonates. Reinforce the need for routine lab monitoring for calcium, phosphorus, and PTH levels, and encourage regular follow-up appointments. Finally, evaluate the effectiveness of your nursing care. If your plan is effective, the patient will be able to identify and report symptoms of calcium imbalance early, remain free from injury, and maintain normal calcium levels. Pheochromocytoma is a rare but important adrenal medulla disorder. The adrenal glands sit on top of each kidney and have two main parts, the cortex, outer layer, and the medulla, inner layer. The medulla's job is to release epinephrine and norepinephrine, also called catecholamines. These are the hormones that trigger our fight or flight response. A pheochromocytoma is a tumor of the adrenal medulla that causes excessive secretion of epinephrine and norepinephrine. Most of these tumors are benign, but the hormones they release can be very dangerous if untreated. The excess catecholamines cause the body to stay in a constant state of stress, even when no danger is present. The cause of most pheochromocytomas is unknown, but about 1/3 of cases are hereditary. They may run in families or occur as part of genetic syndromes such as multiple endocrine neoplasia type 2, MEN2. When the tumor secretes too much epinephrine and norepinephrine, the heart rate, blood pressure, and metabolic rate all increase, placing the patient at risk for severe complications like stroke, heart failure, or organ damage. The signs and symptoms are directly tied to the overproduction of stress hormones. The classic triad is severe hypertension, headache, and sweating, but patients often experience several other fight or flight symptoms as well. These include hypertension, blood pressure can become dangerously high or fluctuate. Tachycardia, fast heart rate, often over 100 beats per minute. Palpitations, a pounding or racing heart sensation. Tremors and nervousness. Diaphoresis, profuse sweating. Anxiety or a sense of doom. Severe headache and vision changes. Because of these surges in catecholamines, blood pressure can spike suddenly and severely. A patient may appear flushed, anxious, and trembling. If uncontrolled, this can lead to stroke, seizures, psychosis, or heart attack. To confirm the diagnosis, a 24-hour urine collection is done to measure metanephrines and vanillyl mandelic acid, VMA. These are breakdown products of epinephrine and norepinephrine. It's very important to avoid caffeine, smoking, and certain medications like decongestants, amphetamines, or beta blockers before and during the test because they can cause false positive results. If the urine test shows elevated catecholamines, imaging studies like a CT scan, MRI, or nuclear scan help locate the tumor. The primary treatment for pheochromocytoma is surgical removal of the adrenal gland, a procedure called adrenalectomy. If both adrenal glands are removed, the patient will need lifelong hormone replacement therapy because the body will no longer produce adequate cortisol or aldosterone. Before surgery, the patient is started on medications to stabilize blood pressure and heart rate. These include alpha blockers to relax blood vessels and lower blood pressure, beta blockers to slow the heart rate, calcium channel blockers to reduce the workload on the heart. Dietary education is also important. Patients must avoid foods high in tyramine, such as aged cheese, red wine, beer, chocolate, and smoked meats. Tyramine can cause a sudden and dangerous spike in blood pressure by triggering additional catecholamine release. After surgery, the nurse should monitor blood pressure, heart rate, and blood glucose levels closely. Hypoglycemia can occur postoperatively because the sudden drop in catecholamines increases insulin sensitivity. As LPNs, our main focus is to monitor for signs of hypertensive crisis, severe headache, visual changes, chest pain, confusion, and report immediately to the RN or provider. We also provide patient education about avoiding triggers, maintaining regular follow-up testing, and recognizing symptoms of both high and low blood pressure. When the nursing care plan is effective, the patient's blood pressure and heart rate remain stable, and they are free of headaches, palpitations, and other symptoms of catecholamine excess. Addison's disease occurs when the adrenal cortex cannot produce enough of the hormones cortisol and aldosterone and sometimes androgens. These hormones are critical for maintaining stable blood pressure, electrolyte balance, and glucose levels. Cortisol supports the body during stress and helps regulate blood sugar, while aldosterone maintains sodium and potassium balance and keeps fluid volume within a normal range. When these hormones are low, the body cannot respond appropriately to stress, maintain adequate blood pressure, or regulate electrolytes. In primary Addison's disease, the adrenal glands themselves are damaged and cannot function normally. The most common cause is autoimmune destruction of the adrenal cortex. Other causes include tuberculosis, fungal infections, cancer, AIDS, and complications following bilateral adrenalectomy. Secondary Addison's disease occurs when the pituitary gland or hypothalamus does not produce enough ACTH to stimulate the adrenal glands. This can also happen when long-term corticosteroids are suddenly stopped because the body's natural cortisol production has been suppressed. The symptoms of Addison's disease reflect the loss of both cortisol and aldosterone. Patients often present with low blood pressure due to sodium and water loss, along with elevated potassium levels. They may feel fatigued, dizzy, weak, and dehydrated. Because cortisol is low, blood sugar may drop, causing symptoms such as nausea, vomiting, weight loss, and poor ability to cope with physical or emotional stress. One classic sign is hyperpigmentation, which appears as bronze or darkened patches on scars, the knuckles, elbows, and inside the mouth. This occurs because high ACTH levels stimulate melanin production. Women may notice decreased body hair or menstrual changes due to reduced androgen levels. A serious complication is Addisonian crisis, which can occur during illness, injury, or sudden withdrawal of steroid medications. This is a medical emergency characterized by severe hypotension, shock, dehydration, and altered mental status. Diagnosis involves checking serum and urine cortisol levels, blood glucose, electrolytes, and BUN. An ACTH stimulation test is used to determine whether the adrenal glands respond appropriately when stimulated. One of the most life-threatening complications of Addison's disease is the Addisonian crisis, also called adrenal crisis. This is a true medical emergency that requires rapid recognition and treatment to prevent death. An Addisonian crisis occurs when the body is suddenly deprived of adequate levels of cortisol, a critical hormone that helps the body respond to stress, maintain blood pressure, and balance fluids and electrolytes. In patients with adrenal insufficiency, a crisis is often triggered by severe stress, such as infection, surgery, trauma, or emotional stress, when the body's demand for cortisol increases but the adrenal glands cannot meet that demand. It can also happen when a patient suddenly stops taking corticosteroid medication, which suppresses the body's own cortisol production. Let's look at the key signs and symptoms on this slide. First, profound dehydration occurs because the body loses sodium and water while retaining potassium. This is due to a lack of aldosterone, a hormone that normally helps conserve sodium and water in the kidneys. As dehydration worsens, blood volume drops, leading to severe hypotension, a dangerously low blood pressure that can progress to shock if not treated quickly. Because cortisol is essential for maintaining blood glucose, its absence causes hypoglycemia. The brain depends on glucose for energy, so the patient may show signs of confusion, irritability, or lethargy, and may eventually slip into a coma if untreated. At the same time, potassium levels in the blood rise, a condition called hyperkalemia. Elevated potassium can cause cardiac arrhythmias and, in severe cases, cardiac arrest. When dehydration, shock, and hypoglycemia all occur together, the body cannot sustain circulation or oxygen delivery, leading to death if emergency treatment is not started immediately. Prevention is critical. Patients taking corticosteroids must never stop their medication abruptly. Instead, doses must be tapered gradually under medical supervision to allow the adrenal glands to resume normal hormone production. LPNs play an essential role in educating patients about adrenal crisis prevention. Teach them to recognize early warning signs, such as extreme fatigue, dizziness, nausea, and darkening of the skin, and to carry an emergency steroid injection kit, hydrocortisone, at all times. Encourage them to wear a medical alert bracelet indicating adrenal insufficiency so that emergency providers know they need steroid support during illness or injury. In an adrenal crisis, treatment must begin immediately. The patient will receive IV fluids, usually normal saline with dextrose, to replace lost fluids and correct low blood sugar. High-dose IV glucocorticoids, such as hydrocortisone, to restore cortisol levels quickly. Electrolyte replacement, including sodium, to correct hyponatremia, and interventions to lower dangerously high potassium. Continuous vital sign monitoring is essential. Watch for hypotension, tachycardia, and signs of shock. The nurse must also monitor serum electrolytes and glucose levels closely and report any abnormal findings immediately to the RN or healthcare provider. Once stabilized, patients are transitioned to oral steroid therapy and educated on lifelong hormone replacement and stress management strategies. Cushing's syndrome represents the opposite problem of Addison's disease. Instead of hormone deficiency, the body is exposed to too much cortisol over time. This chronic elevation of cortisol is also known as hypercortisolism. The excess may come from the body producing too much cortisol on its own or from long-term use of corticosteroid medications such as prednisone. When the excess cortisol is caused by an overactive pituitary gland that releases too much ACTH, we refer to it specifically as Cushing's disease, which is a subtype of Cushing's syndrome. To understand how Cushing's syndrome develops, it helps to review the hormones of the adrenal cortex, often remembered by the phrase salt, sugar, and sex. Aldosterone controls sodium and water balance. Cortisol regulates metabolism, the stress response, and inflammation. Androgens contribute to hair growth and other secondary sex characteristics. In Cushing's syndrome, cortisol levels stay abnormally high throughout the day instead of following a normal rhythm. This persistent elevation overstimulates multiple body systems and also affects aldosterone and androgen levels. As a result, patients may retain fluid, develop electrolyte imbalances, and experience hormone-related changes such as acne or excess facial hair. Long-term glucocorticoid therapy is the most common cause of Cushing's syndrome, especially in patients being treated for chronic inflammatory or autoimmune disorders like asthma, COPD, rheumatoid arthritis, or lupus. Endogenous causes include pituitary tumors that secrete excess ACTH, adrenal tumors that overproduce cortisol, and tumors in other parts of the body that release ACTH, which is known as ectopic ACTH secretion. Cushing's syndrome produces a very recognizable pattern of symptoms. The hallmark feature is weight gain in the trunk and upper body, while the arms and legs remain thin. This central obesity results from abnormal fat distribution. Many patients develop a rounded moon face and a fat pad on the upper back known as a buffalo hump. The skin becomes thin and fragile, bruising easily, and purple stretch marks may appear on the abdomen or thighs. Muscle weakness and osteoporosis increase the risk for fractures. Because cortisol acts as a glucose-raising hormone, many individuals develop hyperglycemia or diabetes. High blood pressure and low potassium levels are common due to sodium and water retention. Women may experience acne, hirsutism, and menstrual irregularities. Mood changes such as irritability, anxiety, and even steroid-induced psychosis can occur. Poor wound healing and frequent infections are also common because excess cortisol suppresses the immune system. These changes show how cortisol excess affects nearly every major body system. Diagnosis begins with identifying these classic physical features, and then laboratory and imaging tests are used to confirm hypercortisolism and determine its cause. A 24-hour urine cortisol level or plasma cortisol level helps measure the total cortisol burden. ACTH levels help identify whether the problem is coming from the pituitary or the adrenal glands. The dexamethasone suppression test evaluates whether cortisol production can be suppressed. In Cushing's syndrome, cortisol remains elevated despite the medication. Electrolytes often show low potassium and high sodium. Imaging studies such as CT scans or MRI are used to identify pituitary or adrenal tumors. This illustration highlights the key physical changes found in Cushing's syndrome that result from prolonged exposure to high levels of cortisol, whether from endogenous overproduction by the adrenal glands or from long-term corticosteroid therapy. Starting at the top, you can see the patient's round moon-shaped face and red cheeks. These occur because cortisol causes fat to redistribute and increases fluid retention, giving the face a puffy appearance. The thinning hair and sometimes bald patches result from changes in androgen and cortisol balance. Moving down the body, you'll notice fat pads over the upper back, called the buffalo hump, and central obesity, the buildup of fat around the abdomen while the arms and legs remain thin. Cortisol causes fat to be mobilized from the extremities and stored in the trunk and back, leading to this characteristic body shape. The pendulous abdomen, loose-hanging belly, is another hallmark of long-term cortisol excess. Next, notice the thin, fragile skin and the purple striae, or stretch marks, that appear on the abdomen, thighs, and breasts. These occur because cortisol weakens the collagen fibers in the skin, reducing elasticity. Even minor bumps or pressure can cause easy bruising, ecchymosis. Patients also experience slow wound healing, which is due to cortisol's suppression of the immune and inflammatory responses. Now focus on the musculoskeletal effects. The arms and legs become thin because of muscle wasting caused by protein breakdown. The bones also lose calcium and strength, resulting in osteoporosis and pathologic fractures, fractures that happen with very little trauma. This makes fall prevention a critical nursing priority. Cortisol excess also contributes to hyperglycemia and hypertension, although these are not visible in the diagram. Patients may experience fatigue, mood changes, and depression, and women often have amenorrhea, no periods, or facial hair growth, hirsutism, due to increased androgen activity. It's important to remember that not every patient will show all of these features, but this overall appearance is quite characteristic of Cushing syndrome. As nurses, when you see a combination of moon face, buffalo hump, thin skin, purple striae, and central obesity, think cortisol excess. Nursing interventions for Cushing syndrome. Patients with Cushing syndrome experience fragile skin, fluid retention, muscle weakness, and immune suppression, which all increase the risk for complications. Nursing interventions should focus on skin integrity, infection prevention, fluid balance, and emotional support. Start by emphasizing daily weights. Cortisol causes the body to retain sodium and water, leading to fluid volume excess. Monitoring weight daily is the most sensitive indicator of fluid retention. Teach patients to weigh themselves at the same time each day using the same scale and to report a gain of more than 2 pounds in 24 hours. Because Cushing's patients have fragile, thin skin, careful skin assessment is essential. Observe the skin for redness, tearing, or open areas during every position change. Assist patients to reposition at least every 2 hours to prevent pressure injuries, and use a lift sheet to move them in bed. This prevents friction and shear, which can tear the skin. Avoid using harsh soaps or hot water, as these strip natural oils and further weaken skin integrity. Instead, encourage the use of mild cleansers and moisturizing creams to keep the skin hydrated and intact. When securing IVs or dressings, avoid tape whenever possible because removing tape can tear fragile skin. Instead, use soft wraps or secure devices. For high-risk patients, a specialty pressure-reducing mattress may be ordered to reduce the risk of pressure injury, especially if the patient is immobile or emaciated. Nutrition plays a major role in healing and prevention of complications. A dietitian consult is often needed. Teach the patient to follow a low-sodium, high-potassium diet to help balance electrolytes and minimize fluid retention. Encourage high-protein foods to support muscle and tissue repair, as cortisol promotes protein breakdown. Next, we need to think about infection control. Cortisol suppresses the immune response, which increases susceptibility to infections. Nurses should monitor for early signs of infection such as redness, warmth, drainage, or fever, and report them immediately. Teach patients and family members the importance of good hand hygiene before and after care, and to avoid exposure to anyone who is ill. Encourage vaccinations, particularly influenza and pneumonia, PNA, to reduce risk of respiratory infections. For patients who develop hyperglycemia due to increased cortisol levels, insulin may be needed since oral hypoglycemics are often ineffective. This means LPNs should monitor blood glucose levels and collaborate with the RN to administer insulin as ordered. Referral to diabetes education classes helps the patient and family learn long-term self-management skills, including diet planning and blood sugar monitoring. Finally, remember the importance of emotional support. The physical changes caused by Cushing syndrome, such as weight gain, facial rounding, and hair growth, can greatly affect a patient's body image and self-esteem. Approach the patient with empathy and acceptance. Encourage them to verbalize feelings and concerns. Creating a supportive environment helps reduce anxiety and promotes trust between the patient and the nurse. An adrenalectomy is the surgical removal of one or both adrenal glands. This surgery may be performed for conditions such as Cushing syndrome, pheochromocytoma, or adrenal tumors. Because the adrenal glands produce cortisol, aldosterone, and androgens, they play a major role in metabolism, electrolyte balance, vascular tone, and the body's ability to respond to stress. Removing one or both of these glands requires careful preparation and close monitoring to prevent complications. Before surgery, the priority is stabilizing the patient's fluid and electrolyte balance and preventing adrenal crisis. Cortisol and aldosterone regulate sodium, potassium, and glucose levels. So many patients arrive with abnormalities such as high sodium, low potassium, or high blood glucose. These imbalances must be corrected prior to surgery to reduce the risk of cardiac dysrhythmias, blood pressure instability, or delayed healing. Glucocorticoids, such as hydrocortisone, are given preoperatively to prevent sudden hormone deficiency once the adrenal gland is removed. If both glands are scheduled for removal, hormone replacement typically begins before surgery and continues for the rest of the patient's life. Preoperative nursing responsibilities include frequent monitoring of electrolytes and blood glucose, administering ordered medications, and preparing the patient physically and emotionally for the procedure. Teaching focuses on what to expect after surgery, including the incision location, pain control, and the need for close observation in a critical care or step-down unit. Patients are instructed in deep breathing, coughing, and incentive spirometer use to reduce the risk of postoperative respiratory complications. In some cases, depending on the underlying cause of the hormone imbalance, patients may undergo a hypophysectomy instead. For example, if the issue lies in excessive ACTH production by the pituitary gland, removing the adrenal glands alone would not correct the disorder. Postoperative care begins with standard surgical monitoring but requires additional vigilance because of the risk for adrenal crisis. A sudden drop in circulating cortisol can lead to profound hypotension, shock, hypoglycemia, and dangerous electrolyte disturbances. Nurses closely monitor vital signs, intake and output, electrolyte levels, and blood glucose. Cortisol plays an important role in maintaining vascular tone and fluid balance, so patients may experience significant fluid shifts. Careful monitoring of urine output, the presence of edema, and blood pressure trends is essential. If both adrenal glands have been removed, the patient will require lifelong hormone replacement therapy with glucocorticoids to replace cortisol and mineralocorticoids to replace aldosterone. It is critical to teach patients that these medications must never be stopped abruptly, as doing so can trigger adrenal crisis. If only one adrenal gland is removed, the remaining gland often compensates over several weeks or months, allowing the patient to discontinue replacement therapy. Additional postoperative responsibilities include monitoring for infection, observing the incision site for bleeding, and managing the patient's pain effectively. Education continues throughout recovery, emphasizing medication adherence, stress management, and early recognition of adrenal insufficiency symptoms such as fatigue, dizziness, salt cravings, and low blood pressure.